A 48-year-old man is brought to the clinic because of a 2-week history of watery diarrhea occurring several times daily. He underwent surgical resection of the terminal ileum 4 months ago due to mesenteric ischemia. He has no fever or abdominal pain. Vital signs are normal. Abdominal examination shows mild distension and hyperactive bowel sounds. Laboratory studies are unremarkable. Which of the following is the most likely cause of this patient's diarrhea? Choice A, complication of mesenteric ischemia. Choice B, decreased levels of bile acids. Choice C, oversecretion of vasoactive intestinal peptide. Choice D, impaired absorption of cobalamin. Choice E, decreased somatostatin secretion. I'll wait 5 seconds and answer the question. USMLE likes giving you questions about either ileal resection or Crohn's disease involving the ileum. Whenever you think about the ileum, I want you to think about a couple things. This is, of course, where vitamin B12 and intrinsic factor are reabsorbed. It's also where bile acids are reabsorbed. Once you know those two, you can kind of figure out the rest of it based off of the physiology of those two things. B12, of course, we would think of pernicious anemia or a vegan. Those tend to be classic vignettes that they would give you for B12 deficiency alongside ileal resection. But more relevant to this question is the bile acid resorption. So as mentioned, bile acids are reabsorbed in the ileum, and in the setting of decreased resorption, like in an ileal resection, you're going to have more bile acids spilling over into the colon, essentially, and this can cause diarrhea, which is what you see in this patient. Choice B is correct. The other things I could have talked about, but I didn't put into this question, is how this can lead eventually to a fat-soluble vitamin deficiency if it's very severe, so ADEK deficiency. This doesn't come up as often with ileal resection because it's not the first thing you think of. When they give you ADEK deficiency on USMLE, they're more likely to give you something like cystic fibrosis or something. Just something that would make it so that fat is not reabsorbed as well. But I'll just go ahead and mention it here just so you know that it is possible to get fat malabsorption in ileal resection as well. Anyway, some of the other things that will happen is that because you are not reabsorbing your bile acids as much, your bile will become supersaturated with cholesterol, and it will increase the odds of gallstones in this patient. So that's another way this could have presented, right? I could have given you, for example, colicky, abdominal pain after meals or something. The final thing I want to talk about here, and they really like this for Crohn's disease as well, is that if you have a fat malabsorption, it can bind to calcium later on in the GI tract, and that will lead to oxalate not binding calcium, and it will get reabsorbed by the body, and this will increase the risk of calcium oxalate kidney stones. So this is why in Crohn's disease and ileal resection, you might have an increased risk of nephrolithiasis. So let's just take a look at some of these other answer choices. Choice A, complication of mesenteric ischemia. I mean, this is possible. I mean, he did have mesenteric ischemia already, but he's already received treatment, and if you wanted to believe that this was some kind of recurrence or something, he has no systemic signs. I mean, if he had mesenteric ischemia, he would probably have pretty bad abdominal pain. Choice C, oversecretion of vasoactive intestinal peptide. This is describing a VIPoma. This is a rare pancreatic neuroendocrine tumor that leads to large amounts of watery diarrhea. The vignette will look completely different from this. VIPomas cause very, very severe watery diarrhea. They'll be going several times a day. And as mentioned, if this patient had a malignancy, he probably would have some systemic signs of it as well. Choice D, impaired absorption of cobalamin. As mentioned, ileal resection or Crohn's disease that has ileal involvement can lead to B12 malabsorption, but it has nothing to do with this patient's diarrhea, really, so it's just unrelated to the question that's actually being asked. Choice E, decreased somatostatin secretion. Somatostatin decreases the gastric proton and pepsinogen secretion, It decreases pancreatic and small intestine fluid secretion, decreases gallbladder contractions. It's basically the GI hormone that makes everything come down. That's the general way I like thinking about it. And it gets stimulated to be released when acid enters the duodenum. Somatostatin, in fact, can be used to treat VIPoma that we mentioned before, because, as mentioned, it kind of brings down most of the GI hormones. In theory, a lack of somatostatin could cause diarrhea, but as mentioned with all the other illnesses, if this patient had some weird somatostatin secretion, like a tumor, then we would probably see some kind of systemic signs of it as well. So bring it back. When you talk about the ileum, I want you to think about B12, and I want you to think about bile acid absorption. B12, of course, a favorite of USMLE for megaloblastic anemia that has a high methylmalonic acid level. And there's just all kinds of ways I could have asked this question, right? So I think it's important you more just remember the ileum is related to B12 and it's related to bile acids, and you kind of figure out the rest of what can happen based off of that. I hope you found this video helpful. I'll see you in the next one.